Thank you very much, everybody, for joining this third webinar in the series from the Observatory webinar series on the COVID-19 response. In today's webinar, we are going to talk about an especially topical subject, namely hospital care and COVID-19, balancing surge capacity during the pandemic with regular services and keeping regular services up. Now that we're all in our second wave, it seems all over Europe, and especially difficult challenge that all of the countries are facing. So what are we going to discuss in this webinar? We'll of course get an idea of the kinds of strategies that countries are using to balance these two. So what kind of strategies are they employing, but also what lessons have we learned from the first wave, and also is there a change now in the second wave? Are there other strategies being employed? And we want to do this through a program with several speakers from involved also in our HSPM and HSRM network. About that you'll hear a little bit later. The HSRM network is responsible for our COVID-19 health system response tracker. But let me first take you a little bit through the program today. So we will start with a small presentation about HSRM. And then we will move to a presentation from Erin Webb from the University of Berlin, Technical University of Berlin. Erin is heavily involved in the HSRM network, and she's editing 4 country pages, and she's co-authoring 6 articles. Then we will move to England, where Sarah Reed from the Nuffield Trust, and Nuffield Trust also a partner in our HSRM network, and she's a senior fellow in policy and research, and actually she just published a report herself about international responses to COVID and recovering after COVID. Then we will move to Patrick Geurissen, and Patrick Geurissen is a professor in fiscal sustainable healthcare system at the Radboud University, but also a science officer at the Ministry of Health, Welfare and Sport. So he's in both worlds, so he can give us these 2 perspectives. And he has a long track record looking into hospitals. Then we will have Enrique Bernal Delgado. He is a senior scientist at the Institute for Health Sciences in Aragon, and he's our Spanish counterpart in our HSRM monitor. And he's leading a team who's doing all the updates, and he will give us the perspective from Spain. I'm also very glad to say that we have as a discussant Melita Jacob from the WHO. She's now the head of office of the WHO European Center for Primary Healthcare in Almaty, Kazakhstan. And she was also involved in the health system response at WHO side. So she's really well informed on the response in Europe, and she can also provide us with a perspective from non-EU countries. Last bit, we will have a chat box that you can send any questions to. It will be monitored by Erica. So we will take all your questions at the end, not in between, at the end, and we'll make sure to discuss all of them. Without much further ado then, I will ask Erica to give a very brief introduction of the HSRM COVID-19 tracker. Thank you.
First thing to say is, when we're talking about the Health Systems Response Monitor, is that it is a collaboration, and it's a collaboration between the World Health Organization, the European Commission, and the European Observatory on Health Systems and Policies. And the aim is to pull together reliable evidence using primarily public data from a network of credible academic and WHO country experts or country correspondents. And what we seek to do with this HSRM is bring together, check, collect, collate, organize updates on country information to capture what is really going on in different countries' health systems, what they are actually doing to tackle COVID-19. And when we say Europe, we're talking all of Europe, the wider conceptualization of Europe, using the sort of WHO definition going right across to South Caucasus and Central Asia. Okay, so the way that the platform is designed, it supports comparisons across countries, across a range of topics, and you can choose which issues or which countries you want to focus on. It also guides users to the reliable international COVID-19 data by offering all the links to this in one place. Links to the key websites to track the numbers, and to articles on the wider public health initiatives and good practices in this area. We also do cross-cutting analysis, looking at the key themes, and that's very much the work that this webinar series is building on. So the cross-country analysis pulls out the sort of different stories, the different narrative threads, the aim being for it to be interesting, topical, and important. So the analysis section responds to questions that have been raised from the countries themselves, or by our colleagues in WHO or the European Commission, or us as editors. We've spotted emerging issues and pick up on patterns and trends. And what we like to do in these cost-cutting analyses is to give examples and good practices and the links to key documents in this area. And we update these regularly as the policy and practices, and to be honest with you, the pandemic evolves. So, linked to this cross-cutting analysis, we've got a special edition of health policy coming out, but also a special edition of our own in-house journal, EuroHealth, which comes out today. It's going to be hot off the press. Have a look at our website later this afternoon. The links are all on there, but you'll be able to get it. It should go live nowish, so very, very soon. Okay, thank you for your time. Thank you.
Thank you very much, Erica. Let's now move to Erin, who will provide us with an overview of the responses all over Europe.
Good afternoon, everyone. My name is Erin, and I'm based at the Technical University of Berlin, which is one of the research hubs of the European Observatory on Health Systems and Policies. My presentation today will focus on balancing surge capacity and regular hospital services now that COVID-19 has taken over the European region. Most of the information that I will present here is based on the content contained and collected within the HSRM that Erica just described. So first, to understand how countries have responded to the COVID-19 pandemic, we have to consider the different countries' starting points. This first graph shows how countries vary and how often they use healthcare services. Specifically, the x-axis shows the average number of doctor consultations per person per year, with the EU average of 7.5. This varies widely from 2 to 3 doctor consultations per person in Cyprus and Sweden to 11 to 12 in the Czech Republic, Slovak Republic, and Hungary. The graph also shows on the y-axis the number of hospital discharges per year, with an EU average around 170 discharges per 1,000 population. Again, we can see a huge variation here, even between closely neighboring countries. The Netherlands has relatively low discharges per its population, while Austria and Germany are among the highest in the EU. The second graph reinforces this variation by looking at workforce, and in particular, the share of doctors and nurses. And while I don't have a graph here, we can see an even greater variation between countries just looking at ICU beds. Ireland has only 5 beds per 100,000 population, while Germany has over 30 ICU beds. And while these high-level figures already tell us something, we also have to remember that these numbers can also vary widely within a country. And regardless of the starting point, the spread of the virus tested hospital capacity to respond to the needs of patients requiring intensive care. We observed some common approaches used to increase hospital capacity. And overall, all countries quickly implemented or initiated emergency hospital plans to free up the capacity and set up additional ICU beds within existing facilities. The most common strategy was to adapt, reconfigure, and designate hospital wards and spaces to accommodate critically ill patients with COVID-19. After this reconfiguration, hospitals could concentrate COVID-19 patients in separate wards and maintain COVID-19-free spaces for other urgent hospital treatment. In addition, in several countries, facilities such as hotels, dormitories, and rehabilitation clinics, which were available due to the lockdown measures in part, were transformed into transition centers for quarantine purposes. And these places were also used in some places to accommodate discharged patients. To this, capacity from other sectors was also used to supplement public hospitals. In countries with private hospitals, some countries used block booking of private sector capacity to have flexibility throughout the crisis. A few countries created temporary hospitals in conference venues, stadiums, or fairgrounds, and some constructed field hospitals to designate or accommodate less severe COVID-19 cases. We saw some field hospitals being entirely managed by the Army. A fourth approach we observed was that some countries transferred critically ill patients out of saturated hospitals in the hardest hit regions. But a few of these involved medicalized trains to transfer patients both within hospitals between the country and also outside of the country. And we saw several countries implementing monitoring systems for physical infrastructure such as ICU bed capacity. The approaches I outline here largely focus on physical infrastructure, so please join the webinar on November 17th, which will focus more on workforce. Aside from building up capacity, most countries canceled or postponed non-essential services, including non-urgent care and elective surgeries. The definition of essential services varied, but often included urgent treatment, maternal services, chemotherapy, and dialysis. And while countries often define this differently, at the national level, with medical professional groups, certain countries, particularly those have a more decentralized health system, left decision-making to individual physicians. With this caveat in mind, this table shows when and how long a variety of countries have canceled or postponed these treatments. As you can see in the gray shading, the duration lasted from 27 days in Poland to 70 days in Iceland. And as shown as the red shading, Italy implemented the earliest restrictions in Europe at the end of February, and Denmark was among the first to lift these restrictions in mid-April, while Iceland maintained the adjustments until the end of May. Again, some caution is needed in interpreting this table, as this ultimate decision-making was not always centralized, meaning that variation could occur within one country. After considering that so many countries canceled or postponed essential services, I'd like to turn to ways that hospitals are accommodating these while still treating COVID-19 patients. Based on the data from the HSRM, we have identified 5 main strategies that countries use to resume hospital care. The first is separating confirmed and suspected COVID-19 and non-COVID-19 second. The second is increasing the use of virtual treatments and digital services. We also see countries providing staff with regular testing and prioritizing treatments based on medical indication, COVID-19 situation, or severity. Last, we see countries that have private sector capacity using this for the response as well. And the remainder of my presentation will cover these strategies in more detail with country examples for each. So starting with separating COVID-19 patients, and each of these will look at 3 country examples that kind of display the variety of responses used in the European region. So starting with Albania, in the first months of the pandemic, Albania created 2 COVID-19 hospitals and transferred the medical services that were previously conducted in these hospitals to other hospitals in the country. Austria used a more regional approach by designating specific hospitals or hospital units in each region to administer and treat COVID-19 patients. Turning to Bulgaria, the country designated Tuesdays and Thursdays for maternal and child consultations and compulsory vaccinations. It's important to note here that while these are outpatient services, some countries offer these in a hospital setting. So it's important to consider these when designing the response. The second strategy, increasing the use of digital treatments, was one of the most common things when we really saw a leap ahead with this in the European region. Italy provides one example of this, and you can see that there were 174 initiatives just within a few months to enhance the delivery of services through digital technology. It was reported that around 50 of these were specifically related to COVID-19, but the rest had to do with anything from diabetes, cardiology, psychotherapy, and other services that are not related to COVID-19. Montenegro advised all patients with chronic diseases to use an information helpline and call center to avoid hospital visits, and saw the number of checkups for chronic disease patients significantly reduced in the in-person setting to reduce the risk of getting infected in hospitals. Estonia provides a little bit different case. It was a country that actually reported that one of the largest hospitals reported similar levels of service provision in March 2020 compared to previous years. And this was attributed to the quick response at the beginning of the emergency. So the hospital was able to collaborate well with patients and partially rearrange their service provision to remote appointments. However, this was not seen in most of the European region, as many countries reported lower levels of service provision compared to previous years. Next, turning to providing staff with regular testing and starting in France. So after the lockdown first ended in France, the country systematically tested all of its healthcare workers. Lithuania regularly tests staff every 7 days, and this includes social care staff. And more recently in Norway, on September 27th, a COVID-19 outbreak was detected at a university hospital ICU, causing the hospital to postpone the operations and redirect new patients to other hospitals in the region. So this shows kind of the variation between having a more national, wider strategy and have targeted response when needed as well. Next, in terms of prioritizing treatments, in Ireland on July 22nd, the Health Service Executive published a plan called A Safe Return to Health Services, Restoring Health and Social Care Services in a COVID Environment that was intended to last until February 2021. It foresees that different surgeries, procedures, and health screening programs will operate at 50 to 70% of their normal capacity. The Netherlands involved many different stakeholders in creating an urgency list of procedures to prioritize when scaling up regular hospital care. And also in Spain, there were 5 scenarios identified based on the epidemiological situation. And I believe that Enrique and Patrick will describe these in more detail. And then the final strategy that we would like to discuss today is using private sector capacity. And in England, the NHS block book capacity from private acute hospitals. Cyprus also used the emergency and accident departments to treat urgent cases. And the National Purchasing Agency in Greece will reimburse private hospitals for beds, and patients will no longer face co-payments in private hospitals. So wrapping this up a little bit, I also want to look at this article from the New England Journal of Medicine that was published last week with a case vignette of different options for elective surgery during the COVID-19 pandemic. It asked readers to choose whether they would continue to schedule elective surgical procedures, defer all elective surgical procedures, or proceed with the scheduled procedures but defer new cases. And you can see with over 1,000 total responses that it's not clear what the right strategy would be. So to wrap up, perhaps the lesson suggested by the authors that the 2-in-1 health system, one for COVID-19 and one for non-COVID-19, should remain for the duration of the pandemic. So thank you very much for your attention, and I look forward to your questions at the end.
Thank you very, very much, Erin. I think it's a very helpful overview, and I think that final slide is exactly what we're discussing here today. So now we're moving to the country spotlights. We first start with UK, a country that was also faced with its own set of problems, a lean system with, with limited capacity. So Sarah, the floor is yours.
Yeah, so I'm going to start by talking a little bit about the position that the NHS in England, at least, finds itself in now as we approach the second wave, and some of the things we're doing to be able to maintain access to care while we deal with a surge of COVID-19 hospitalizations. So the first thing to say is that, like in other countries, it became really clear early on that COVID-19 was requiring massive trade-offs in how to balance the COVID and non-COVID care. So consistent with policies to defer elective procedures in less urgent services, we saw a massive drop-off in activity across the board by mid-April. Since then, we have been working steadily to be able to restore services, but we've not been able to do that at the pace at which services initially dropped. So the government recently set a target here that we would get mostly back to normal in most services by the end of last month, but you can see here by the dotted lines that we're still some distance from where we would be typically in a non-pandemic year. So this has contributed to what we're seeing, a growing backlog of services and long wait times for care. So by June of this year, we saw that the number of patients who were waiting 18 weeks for planned treatment had grown to about 50%. That's an increase from 16.5%, which is where we were at the start of January. We've also seen things like wait times for diagnostic tests increase. So that's what this chart here is showing on the right, which after that drop off that we saw in the spring during the first wave, we are doing more tests, but again, we're not really near where we would be this time last year. We're about 20% below what we would expect for this time of year. So it's this scenario combined with the onset of winter, and now, as I've described a bit, the growing uncontrolled rise in cases, that means that the English NHS and across the UK is going to continue to rely on a lot of the interventions that we did at the first wave of the pandemic. So a lot of the interventions that Erin described are things that are really familiar to us here. They're things that were been implemented across the country, but this time around, given what I've just described, those grim figures about our ability to restore and get back to normal and the growing backlog, we're really trying to avoid having to cancel services across the board as we did in the spring, though unfortunately we do see some hospitals already becoming overwhelmed and having to make some of those difficult trade-offs and decisions. So even though we're doing a lot of the similar things to build surge capacity, they each come with implementation challenges that I'm going to talk through a little bit now about that kind of limit the amount of extra capacity that we can get or expect. So Erin described this idea of having COVID-free zones or circuits or pathways within hospitals to separate patients. And that is something we're doing across the country. So for example, in surgery, we have 4 different pathways with different levels of infection control depending on patients' risks. But doing the amount of segmentation and reconfiguring services this way does have a cost on efficiency. And we're seeing that hospital capacity is down by about 10 to 30% based on the latest reported figures. And that is, again, playing a real limit on our ability to get back to normal. And a lot of that is for reasons that you might expect. So for example, having to cancel procedures at short notice if patients test positive and not be able to fill that slot quickly. But it also has to do with the fact that the NHS entered this pandemic with fairly outdated physical infrastructure. So things like narrow corridors and entranceways and lifts that make it really hard to reconfigure and make the most of our space to be able to have these segmented zones. Add to this the challenge of staff absenteeism and burnout that make it difficult to maintain these different staff rotas to maintain these zones. And it's also the fact that implementing these strategies can reduce the risk of in-hospital transmission of COVID-19, but they don't eliminate it. And as soon as we're seeing rise of cases in the community, there's a fear that we'll see similar rise in in-hospital transmission, which makes things like routine staff testing essential. But unfortunately, our system here has been beset with challenges that have made it difficult to do this in practice and reach the capacity we need. This is why we're continuing to rely on things like the field hospitals and private sector partnerships that we established in the first wave. But those resources, we did face some criticism that they were being underutilized during the spring. So headlines about field hospitals remaining empty, but that's because a lot of them lack the resources to deal with the most severe cases in the first wave. And this is why this time around, we're maintaining them more as clean non-COVID sites that do things like elective care to help us reduce our backlog. But the challenge here is that we have a finite number of staff here in the NHS. We entered the pandemic with about 100,000 vacancies, and the staff and personnel needed to maintain those field hospitals have to come from somewhere in the system. So the question is then, I guess, where? And there's also a crossover between staff that work between the private sector and the public NHS. So just real questions and things we need to really have in mind as we enter the second wave about how much extra capacity we can reasonably expect and what this means for our recovery overall. So I'll stop there to pass it on to another speaker.
Thank you very much, Sarah. A very good point that staff is also definitely plays a role here. And in 2 weeks from now, exact same day, same hour, there will be a dedicated webinar on that. Now moving to basically a neighboring country, the Netherlands, also a country with a lean system, also was really challenged by constraints in hospital capacity. Patrick, would you take us through your slides and tell us what happened in the Netherlands?
Yes, thank you, Ewout. Hello, everybody. I think you cannot see me. Sorry about it. It's not because of privacy or something, but some technical problem on my side. Yes, I think Ewout was correct. We are, of course, in the Netherlands, a country of limited capacity, also very much skewed to larger hospitals. Could you please do the next slide? Oh, you can see me. Great. Okay. Well, I cannot see you, but I'll see a black picture of Ewout. Sorry about it. So here you see some things on the context of the situation in the Netherlands. As been said on the right bottom side, very decentralized, currently around, well, not around, 11 regional acute care networks that were already existing, are kind of spearheading the coordination on the parts of the hospitals. So what we see, as in other countries, as in the UK, on the top right part of the slide, you know, much less capacity in the first wave in March and April, and now currently what we see is that it's starting to slow down. Just today, 5 out of the 9 hospitals in the Rotterdam area have said that they stopped taking COVID admissions because of capacity struggles, and some hospitals also started to delay surgeries as of today. But the number of cases is going down, so we hope this will be a temporary problem. Now, already Aaron told us a little bit about our urgency list. You see that on the left side, bottom part of this slide. The blue lines are the urgent, so-called urgent procedures. So what has been done is that all DRGs, so around 5,000 DRGs covering around 90% of what's going on in hospitals, that they were coded according to urgent, less urgent, and non-urgent procedures. And what you see here very clearly is that urgent procedures, so cancer operations, cancer surgeries, acute heart problems, etc., have held up quite well and are still around or even a little bit higher currently around what would be normal at the time of the year. But still, we do struggle with capacity, and like other countries, the number of ICU beds is currently going up. So next slide, please. I think from my perspective, what's really important is that I have a strong feeling, and I also see it as a hospital employee actually, that the local resilience of many hospitals have gone up. So many lessons have been learned. Very quick translations, I would say, in official guidelines. So the whole professional community has done a lot, basically, to kind of support hospitals how they should deal with the current second wave. And you see here that, well, actually, you see on the graph here, again, the blue slide are the university clinics. So we do witness that the largest hospitals hold up activity levels on a relatively, on a bit somewhat higher level than, say, the smaller hospitals. And we have a lot of larger hospitals relatively, so I think that's kind of, a good thing. In my own university center, there are around 43, well, not around, there are exactly 43 COVID guidelines. And if you open kind of our intranet, you cannot really pass them. I mean, so it's very broadly communicated. And they kind of deal with the whole situation of what needs to be done. So it's about, of course, more e-visits, but also how do you, do the social distancing and the 1.5 meter hospitals and all kinds of procedures around that. Of course, palliative care for those patients who are expected to pass away. Have been made all kinds of adjustments, and also the post-discharge care with going to nursing homes or home care, other stuff. Of course, like Sarah was saying, many protocols on sterilization, hygiene, and also what are the escalation protocols within the hospital. So when it's when are basically people are dismissed or not, when people are not allowed to go on holiday or whatever anymore. Then it's also very easily to have, the level of care. So the care flow chart, it's in Dutch, sorry about that. But there you can actually see, for example, in the medium part of this guideline, that if you have a patient with serious problems, which needs oxygen, that you might consider remdesivir, for example. That's what it states. But if you have very severe patients with very severe problems, you might consider immunotherapy. So it's actually very, very easy to kind of, see, what we've learned in the past 5-6 months, and how this is now being implemented in the hospitals. So I hope to have give you a very short, brief overview, which I think it's very much in line with, what are basically the lessons in most countries. But so I feel that, this issue of local resilience and how you have learned the local lessons, I think it's very, very, very important. Thank you.
Thank you very much, Patrick. Very insightful. Now we'll move to Spain, one of the countries hardest hit. Enrique, the floor is yours.
Well, this is about Spain, the Spanish health system. You might want to know first a bit of the context where the Spanish system works on. This is actually is a composed of 17 regional health systems that are coordinated, more or less sharing the same features. Basically, the regions are the side where decisions are made in terms of financing and planning. And the hospitals are actually owned by the public sector in the vast majority. There are some differences across regions, but are public hospitals, the majority of them. The staff that is working within the hospitals are actually public servants, and these hospitals are financed using lump sum budget schemes, basically. And the private system is generally speaking is subsidiary to the public system. So it complements the activity the public system can cover or needs to cover, because, for example, the reduction of waiting lists. In this context, and with some differences across regions, we are actually sharing the same concerns as any other health system in Europe. You might have, for example, you can see here that in Aragon, the region where I come from, which is 1.3 million lives where the system is attending. The daily visits of emergency care plummeted 88% and haven't recovered yet, as you can see in this slide. Same happened to elective surgery, actually plummeted in 80%, 88% to be more specific. These are the daily surgical interventions. You can see that within the lockdown, the big lockdown in March and April, the elective surgery plummeted actually. So the point was that we left the lockdown, the strict lockdown, and we started off to recover the system. There was a need of trying to recover surgery, so to get a compromise between COVID patients' attention and non-COVID patients' attention. And then surgery was one of the big elements to take into consideration. So the council, we call it the Interterritorial Council for the Health System, which is the place where the regional ministers of health in the regions are meeting the Ministry of Health and make decisions or make recommendations on how to proceed, decided quite soon in time, a set of rules to make decisions on how to prioritize surgery in the upcoming months. Now we are suffering the third wave actually in some regions. So this applies for the second wave, more or less start off in some regions in September, and for other regions that started off in August, and now they are during the third one. So this slide is collecting very simplistically the kind of rules that where regions might take decisions on how to prioritize patients. As Erin mentioned, there's 5-level risk level scale that actually coordinates the action. It depends on 2 things: the number of COVID patients occupancy rate within the conventional hospitalization and also ICU beds, so intensive care unit beds, but also is nuanced by the epidemiological trends that it might be different, as you can imagine, in every of the 17 regions in the country. So, but the first starting point is that the occupancy rate. So depending on the rate, the decisions that will scale down will differ. In any case, from low risk to emergency, there is a common ground for any hospital in the country, which is that the need of pre-surgical PCR testing for any patient in the 72 hours prior to the surgery. Then there are different strategies depending on, as I say, whether we are in the low risk area, mild risk area, high risk area, or emergency. In the case of low risk area, the regions are, promote to secure beds and staff. Basically, this is about just not increase the number of interventions and just focus on urgent oncological and major conditions, or high need conditions interventions. If there is an increase in the occupancy rate, we are right now in the region between this 25 and 50% of the beds in the region are occupied by COVID patients. So we are now at this point. Then we have to prepare, departments, floors, and staff for further increase in the number of patients to be treated. In that case, what we do is discharge other patients at a higher rate, and then training personnel to be prepared, particularly nurses, to be prepared to an eventual increase in COVID patients. And then the focus is just on urgent oncological surgery, so just prioritizing those types. If we move to high-risk area, then we do need to increase internal capacity, and I will comment now because we were supposed to be on dedicated floors in the region, in the staff, but we are moving to increase in internal capacity, actually. The reason is because the reproductive index at 7 days is increasing since the 1st of October, doubling in 2 weeks' time. The accumulated incidence to 6 per 100,000, and we are actually with a 45% of the intensive care unit beds with COVID patients. So we are increasing internal capacity, which means let's focus on discharging to different hospitals within the system, try to discharge to intermediate units, so for recovery of those in the last days of stay, conditioning reanimation rooms after surgery and surgical theaters as intensive care units, and shift roles. For example, those cardiologists, pneumologists, and anesthesiologists are now trained to be part of the intensive care units, working as intensivists. Then just focus in this level of high risk, just focus on urgent surgery. And then finally, the state of emergency, we have to resort to extraordinary measures, like, for example, resorting to private hospitals, resorting to field hospitals, in the parking lots of the hospitals, etc., and just focus on urgent vital surgery. So yeah, this is very much an overview of the decision-making rules implemented with a variety, of course, across regions and depending on the actual epidemiological trends every single week. Thank you very much.
Thank you very much, Enrique. Now we go to a very quick reflection from Melita on all this, and also, does it mirror actually what you see in the non-EU countries? That would be something that would interest me. Melita.
Yes, thank you very much, and really interesting and very thought-provoking presentations. Certainly in non-EU countries, we have much less data and less well analyzed, but the trends are certainly to this direction. The thought-provoking question that occurred to me listening to the presentations, that we're comparing these trends in utilization to the old trends, and we're talking about returning to the old normal. But was the old normal good? Did it produce the right outcomes? Was it produced efficiently with the right level of care? And let's remember all our conversations prior to COVID, where we were talking about how to indeed reduce emergency room utilization, how to encourage people to go to primary healthcare to a greater extent rather than using specialists. And I think this is very interesting and an important discussion because certainly some of this decline in utilization was appropriate utilization and will have an impact on mortality, but perhaps some of the other decline was sort of inappropriate utilization that would have been resolved by itself. And we have carried out as WHO a survey among our 53 member states with very good response rate, asking key informants about the key reasons for disruptions in essential health services. And they listed a number of demand side factors, supply side factors, and community factors. And what's really interesting is among the demand side factors, the big factor is fear of seeking care. And so at the analogy that comes here is when we were talking about the user charge debate and thinking of user charges as potentially a good instrument to reduce inappropriate utilization, that turned out to be completely unfounded. It turned out that people are not very good judges of when utilization of care is appropriate versus inappropriate. So that is a very blunt instrument. And I think this is what we have to be mindful in discussion as well, is it's very important to think of policy interventions to assuage those fears and not let the patients be the decision maker of when to make that call, but trust it to the professionals. The second thought I want to share, and that will be much shorter, is that we're talking much today about hospitals, and since February we have really focused with a laser focus on hospital capacity, but we have to view hospital capacity, utilization trends, and surge capacity in the context of the whole of the health system, because these all have spillover effects, and in particular onto primary healthcare. Primary healthcare provides big surge capacity to hospital care during epidemic peaks. But then when the epidemic is under control, primary healthcare actually has to catch up on those services that were postponed and delayed, especially for non-communicable diseases and vaccination. And again, our survey shows that there were quite significant disruptions, even in these foundational basic services like NCD management in the primary healthcare context, like vaccination, etc. So in that EuroHealth volume that you guys talked about at the beginning, we have an article about balancing health systems on a seesaw, that you have to reprioritize and redirect resources very rapidly from stage to stage of the epidemic, either to respond to the COVID surge or catch up on the delayed essential health services. And that is something we don't have very good instruments to do. And the slide about priority setting more specifically is perhaps one of the useful ways to support healthcare providers on the front line, on the ground, on making these tough decisions of who needs to seek care when, whose care can be delayed, etc. Thank you very much.
Thank you very much, Melita. Indeed, I think this is going to be the big question. How do we prioritize? Where do we focus? I mean, and this is, of course, something we cannot see without also looking at the other parts of the health systems other than hospitals, obviously. Erica, could I ask you to tell us a little bit what happened in the chat box? I saw there were quite a few questions, and maybe you can group them a little bit, and then we can try to discuss them. In the meantime, perhaps our presenters can switch their cameras on so that we see them, and then we can have a 10-minute or so question round before we wrap up.
Okay, so we've got very little time to run through some very interesting and quite profound questions. So I'm going to group them together. One of them is about comparing elective surgery data and what data are available. I thought that might be something that Sarah and Erin could speak to. That's from Robert Royce. But there are also, are there any, in the comparative work that the two of you have done, are there any country examples of protocols in use for ICU triage or deprogramming usual care? And that's from Lynn Seneca. And any of the other country spotlight people, if they wanted to respond to that, that would be great. And building on what Melita was saying about the link between primary care, elective care, and surge capacity, Ralucha Pop asks, is there an idea that we should be building surge capacity for elective care between the waves into the system, so that we can to try and preempt the wave of non-communicable diseases that might come? And then, yes, there was a question on rapid training of health workforce, but I would like to let people know about the workforce seminar, which is on the 17th of November. But if anybody has any insights into scaling up ICU capacity, particularly with a view to scaling up workforce capacity that they'd like to share today, please do. Go for it.
Let's then first start with Sarah and Erin, and if you can take the question about this data availability. I think there were also some real questions about where did you see the largest drops. I think you both looked at several countries. Do you have an idea? Sarah, perhaps?
I can start by giving a picture from the UK, certainly. So we're fortunate to have fairly recent comprehensive data in our health system. So we have monthly performance statistics that there's been some disruption around COVID, but mostly maintained. But of course, getting an accurate comparative picture with other countries is an enormous challenge. And even within the UK, with each of the devolved countries having different approaches to tracking that data, it can be hard to make our own inter-country comparisons. But at least on the English side, we are fortunate to have a fairly accurate view on a monthly basis. In terms of what we saw, yeah, I can speak a bit about that. So something like by mid-April, we saw about a 73% decrease in elective admissions. Diagnostic activity dropped by 68%. Outpatient attendance is 59%. So it's quite significant. And though that was consistent with the policy approach we took, I mean, we had the NHS never closed. Essential services were meant to be maintained. But I think, as other speakers alluded to, there's real changes in patient behavior. And I think that is something we're really trying to avoid that happening a second time around.
Erin, do you have anything to add on that one? You looked at all the sources.
I would echo Sarah's statement that the data is very difficult to pull out comparatively, but we're already seeing certain things that provide more questions than answers almost. So in Germany, for example, there's 30% fewer heart attacks and strokes, and registration of patients with suspected myocardial infarction decreased by about 25% in Sweden. And so these types of things come into question whether it's patient behavior or if there are fewer kind of triggers for these types of things, and will patients be reporting to the health system later or not recorded in the same way that they normally are. So while I can't say a cross-comparative trend yet across countries, there are certain things that are being reported from certain countries that we're definitely keeping an eye on.
Well, it sounds like we definitely have to improve on the data. You know, that's, I think, one of the overarching lessons. The question about the ICU, I think I want to ask that to both Enrique and Patrick, because, well, you had it on your slide, Enrique, and I know, Patrick, in the Netherlands, it was a huge debate, wasn't it? Just very briefly, we don't have that much time left, but I would like to hear maybe a little bit more specifics, whether you also know of other countries that have these triage. I think that's often the code used in other countries, that there is such a system in place. Patrick?
So I think the debate was actually about personnel. I mean, so the government kind of allowed, I think, €1 million annually for each ICU bed. They have been spread over the country by now, and the larger hospitals got a disproportionately higher share of ICU beds. So smaller hospitals got relatively fewer additional ICU beds. And but the problem, of course, is where do we get the ICU nurses from? Because we need 4 for each bed, roughly. And that means we need 25, 30% more ICU nurses who are not there. So.
But you have a neighboring country that has lots of beds, luckily. That played a big role, actually, in the Netherlands, no?
Yeah, well, less now. But yes, of course. You know, some patients are also being transported to Germany, but currently not that much. I would like to make the comment, though, that if we talk about hospitals and all this and primary care, that we need to be very clear what exactly is a hospital, because the differences between the countries are huge. And for example, in the Netherlands, we have limited capacity. So we have relatively limited, if we go to the former situation, limited overuse with a very well-developed primary care system with no co-pays. So I think it's also very important to much more look into, you know, what exactly is a hospital in a certain country, or what exactly is primary care. And I think we need much more in between, basically, and that the whole COVID kind of pandemic shows, you know, that we need to have much more in between to solve the elective procedure crashes in many countries.
I think that's a very valid point, and also I think that one that was echoed by Melita. Enrique, maybe real quick.
Quick one. Beyond these policies or managerial aspects, if you will, to make decisions on what is the reaction of the hospital, so how a hospital has to move. The clinical side is basically as is supposed to be. I mean, the decision-making process for an intensive care specialist are the same for COVID patients and for non-COVID patients. So those patients that can benefit of the intensive care unit will benefit. There is no doubt on that. So the protocols are the protocols for any kind of severe patient. It's worth those, trying to understand that at the beginning of the pandemic, so the very first days was a different matter, and then the Royal College of Intensive Unit Care provided recommendations about decision making for the intensive care doctors to make decisions on who could benefit the most and who could benefit in terms of making decisions when the supply was actually under risk. But it's not the case right now.
Well, I wish that we could discuss all the questions because there are still a lot more very relevant ones. I would have liked to ask you also, what do you think where we're heading now in your particular countries? But unfortunately, that will have to wait until the next webinar. For now, I would like to ask Erin to give her key takeaways after hearing the discussions and also seeing the other presentations, and then we'll wrap up this webinar. Erin?
Thank you. So I would first echo Melita's point that although this webinar focused on hospitals, we have to look outside hospitals as well. And to Patrick's point, kind of what is a hospital defined as well. And also think about the transitions between different treatment areas. So especially now that we're learning more about long COVID, how these patients are stepped down also between the hospital and the nursing home, for example. And also, I think it's important to note that some of these strategies that have been adopted as a result of the pandemic, we don't know whether they will be temporary measures or whether they'll be around in the health systems for longer. And whether this is a conscious decision or if it's just a matter of inertia, whether the hospitals and health system more broadly will transition back to the way it was. So for example, looking at digital tools, we have to think if we've seen this really increasing, but if it stays around, what does that mean for patient behavior and patient access? And when we're relying on digital tools, do we have the infrastructure, workforce, and all of these supporting mechanisms in place? So kind of looking towards the future, which things will remain longer term and which things are just a emergency response. I'm very curious to follow that.
Thank you very much, Erin. Indeed, there are, I think, many more questions. People are posting questions. We will save them and we will get back to them somehow. Just as a final comment to you, next week we're going to talk about same date about financial or actually payment systems under COVID, which can have repercussions for or more long term. And then in 2 weeks, as already mentioned, we have a workforce seminar. So please, I hope that we'll see you there and we can discuss some of the other questions hopefully there as well. I would like to thank all the speakers today and also you viewers for joining us today. I think we had a very interesting short session, but that's the whole idea. We only want to take 1 hour during lunch. Final thing, as soon as I close, you will have a pop-up where you can evaluate this session. And it's for us really helpful to target our work better. So please take some time to fill it out. That will help us tremendously. So thank you very much. And I hope to see you next week.